DNR stands for Do Not Resuscitate. Do Not Resuscitate is a restriction of performing cardiopulmonary resuscitation, also known as CPR. CPR is a specific medical procedure performed to recover the heart when heart failure occurs. Stephen Miles, Ronald Cranford, and Alvin Schultz stated that a decision not to resuscitate is considered for a variety of reasons: a request by a patient or a family member, advanced age of the patient, poor prognosis, severe brain damage, extreme suffering or disability in chronically or terminally ill patient, and in some instances, the enormous cost and personnel commitment as opposed to the low probability of patient recovery. A request for DNR is often made by a patient in respect to quality of life if CPR was to be performed. With the patient's wishes and quality of life at high priority, in many cases a DNR order can be formed by a patient's family or doctor if the patient is not capable of making such a crucial decision. This is where ethical issues begin to arise.
Initially, the DNR method was performed in the 1960s. Adults and children who had suffered from cardiac arrest were resuscitated by the simple method by anesthesiologists. Soon after, the practice known as cardiopulmonary resuscitation, CPR, had become a routine emergency procedure performed by any trained health professional, as it was an effective means of resuscitating a patient. However, in 1974, the American Heart Association recognized that many patients who received CPR survived with significant morbidities. It was apparent that although resuscitating the patient had given the individual the opportunity to live an extended life, there is a possibility that they would then have to undergo more extensive operations and treatment in the intensive care unit. However, the success rate of DNR in the US was only 10 to 15%. Family of the patients were unsettled by the DNR method being the choice of the patients, as many believed that their loved ones were not in a competent state of health to understand what is the best option for them. Instead, people had wanted the form to be given to the family so that it should be the family's decision to decide whether to choose to persist in seeking medical treatment. Issues regarding individuals' religious faiths had also been a factor to this ethical dilemma, as the Catholics had believed that it is within God's decision to select whether one is to live on this earth. Starting in the mid-1970s, policies had been implemented within hospitals on DNR order, due to concerns that universal CPR would cause more harm than benefit for some patients. Hospitals provided the option to not proceed with DNR for any individual, regardless of the condition and success rate. It is the patient's autonomous right to decide whether they wish to be resuscitated. It gives patients time to consider the level of success if they were to undergo the methods of DNR. As for some cases, it is the patient's well-being that resuscitating them will do more harm than good. However,
when discussing the path the patient may make with regards to resuscitation, multiple parties are involved in the decision: the patient, medical practitioners, and family members. A patient who opts for DNR or refuses medical intervention may experience disagreement amongst all parties involved. This makes it a cause of concern in the medical sphere. While a medical practitioner's primary role is to prolong life, it is to do so whilst keeping the patient's best interest at heart. This raises discussion into the bioethical principles concerning DNR. Firstly, it's a patient's autonomous right to elect voluntarily whether to consent to or deny treatment. Non-maleficence would oppose performing CPR when more harm can be brought to the patient. It is not uncommon that while performing chest compressions, patients may suffer from broken ribs or severe bruising. However, it could be argued that not performing CPR could also result in harm, that is, allowing a patient to die. Practitioners are expected to uphold and protect their patients' interests and well-being under the guise of beneficence, and so should act to benefit the patient by performing CPR. However, others would argue that facilitating a dignified death could be equally viewed as beneficent. The dynamic interplay between these bioethical principles highlights how contentious DNR is in today's medical epoch.
DNR is a complex issue that needs and deserves greater discussion with health professionals, family, and research into the factors affecting the outcome and the benefits from life-sustaining treatment, which includes cardiopulmonary resuscitation. The following issues may impact someone's decision to choose the option of DNR. Age plays a major factor that may encourage patients to choose the path of DNR. With elderly age trails illnesses, and over a period of time, the ongoing sickness may encourage the patient to die peacefully. And while there usually comes a time when continued treatment will no longer reduce symptoms and may not heal the patient, and they may be at the stage of the disease where the person continues to decline down the path of death. Many may choose the option of dying in a natural way, without machines or health professionals' assistance, and believe that dying is a biological part of life, and that there is a certain time and place that a person must die, and it is an intended event in our lives. The presence of family or friends may also impact the decision to choose DNR. Having no relatives may create loneliness for the patient and choose to end their life when the time comes, encouraging them not to be resuscitated. Also, the costs following the resuscitation may concern people in the lower socio-economic status, taking into the consideration the treatment needed after the incident, medication requirements, and the following checkups by health professionals. As well, the ongoing treatment in hospital after cardiopulmonary resuscitation may cause the patient to feel pain and distress, which may follow into more health or mental issues, creating additional illnesses for the patient. Choosing DNR could allow the family, caregiver, or friends of the patient at a sigh of relief of deciding to turn the machines off, which may be a more difficult decision psychologically.
Cannot believe you chose DNR.
Why wouldn't you choose DNR? It's natural causes, bitch.
Well, what about me, you selfish bitch? And your family? Don't you care about how we feel about this?
I'm a poor uni student. I wouldn't have enough money to support medical bills following a resuscitation.
Centrelink back payments? And besides, wouldn't you want to do anything possible to live?
But there are some people out there who, when resuscitated, live a poor quality life. Sometimes letting nature take its path is better than meddling with an uncertain fate.
That's heavy, babe. You can't, measure life. Money shouldn't be compared to living, to the fullest with your bitches.
But why shouldn't I be resuscitated? If I could catch more illnesses and feel more pain, I'd rather die.
But, that's just so sad. Everyone's gonna miss ya. How will we go on?
My family are cluey about this and just get me. There's a chance of me being in the worst state of health if resuscitated, which would be so devo. For them, more devo than my DNR choice.
But babe, medical technology is high-tech as fuck. You're thinking old school.
Nothing is perfect or certain. I don't want to build up of all those toxins in my system from all the meds and all my happy juices.
But you'll be treated so differently in hospitals. They won't even give a rat's ass about you, honey.
Well, that's the risk I'm willing to take. Besides, every health professional should respect my decision and not have to impact my treatment for those minor things.
Fine. Whatever. We'll agree to disagree.
I'm a Barbie girl in the Barbie